Good afternoon, everyone. Thank you so much for joining Jet Foundation's virtual workshop series. For those of you who do not know me, my name is Danielle Edwards, and I'm Jet Foundation's Community Engagement Manager. We are so excited to kick off our webinar today about respiratory care in Duchenne muscular dystrophy patients, and we'll be starting in just a few moments, so please just hold on with us. Good afternoon, everyone. Thank you so much for joining Jet Foundation's virtual workshop series. My name is Danielle Edwards. For those of you who do not know me, I am Jet Foundation's Community Engagement Manager. We're just waiting for a few more people to just sign on to the webinar before we kick it off. So just, again, please just hold on for a few more moments. Hello again. Thank you for all of those who just got on. And thank you so much for joining Jet Foundation's virtual workshop series. My name is Danielle Edwards, and I'm Jet Foundation's Community Engagement Manager. We are so excited to have Dr. Oren Kuffner here today with us, who is a pulmonologist from Children's Hospital, Colorado, that will be speaking about care in Duchenne muscular dystrophy patients, respiratory care in Duchenne muscular dystrophy patients. For any questions you may have for him, please just drop them in the chat section below, and we will answer them after the presentation is complete. With that being said, please enjoy the webinar, everyone, and I'll pass it over to you, Oren.
Hi, everyone. I hope you guys can see me. I prefer to talk where people can see me, but I can't see you, so I guess enjoy my face and the talk. So I wanted to talk today about breathing basics and beyond in Duchenne. And looks like I don't have the mouse yet. There we go. Oh, too fast. Okay, so I'm going to tell you everything you need to know about breathing in Duchenne in 25 minutes, I hope. And then I'm going to leave time for some questions if you have them. It looks like my mouse doesn't work if I'm in video. Okay, sorry, the video has to go away.
Maureen, I think it's just slightly delayed. I think if you can leave your video, maybe just click those arrows at the bottom.
Okay. Oh yeah, there we go. Okay, let's try this again, guys. 25 minutes and ticking. All right, so here's our outline for today. We're going to talk about some breathing basics. What's normal breathing? We'll do that pretty quickly. We'll talk about pulmonary function tests and other ways to assess respiratory function, and then we'll talk about breathing in Duchenne. After that, we'll move over to treatment, talking about airway clearance, breathing support, and acute illness, and then a brief comment on COVID-19. There we go. Yeah, okay. So normal breathing is essentially a balancing act between the tendency of the lungs and the airways to collapse down, to shrivel up, and the respiratory muscles and the chest wall's tendency to expand the chest. And when we reach a balance of the tendency to collapse and the tendency to expand, we have a somewhat inflated chest. And of course, all of that is controlled by our brain telling the respiratory muscles to inhale and exhale. So that's kind of the basic understanding of the chest wall, or the pump of breathing. Now we have breathing muscles, of course. So the muscles that we use to inhale are the most important muscles. And those are mainly the diaphragm, which sits between the chest and the abdomen, pushes the abdominal contents down and draws in air. We also have other muscles of inhalation, and those are the external intercostal, so muscles between the ribs that help expand the chest outward and forward and back, not just pulling down, which is what the diaphragm does. And then we have some accessory muscles in our neck that help pull the chest up a little bit. And those are more important when we really want to take a big deep breath, like to scream, laugh, cry, sigh, cough. The muscles of exhalation or expiration tend to be more passive. So usually just exhaling is passive. It's the diaphragm relaxing and then air comes out. But if we, again, need to cough or scream or shout, then we need muscles that help squeeze the chest even tighter. So here are my silly cartoons of a chest at rest. So this is when you exhale. On the left side of the screen, you're going to see a side view or a profile of the chest, and it's labeled back, front, and then chest and abdomen. The diaphragm will be the dotted line in red. And on the right side, you'll see a frontal view of the chest with the right and left lungs, and then the abdomen is the circle. So this is at the end of exhalation, the lowest lung volumes, and then when we inhale, the diaphragm pulls down, contracts, pulls down, and you see it pushes the abdominal contents down and draws air into the chest to make it bigger. So that, and then we rest, we exhale, the diaphragm relaxes, rises back up, and helps push air out of the chest, and the abdomen can rise back up. So the other thing to talk about is normal airway clearance. I mean, how do we get stuff out of our chest? So there's essentially two ways to do this. One is through these microscopic hairs called cilia in the respiratory mucous membranes that beat in an upward fashion. And then there's also cough. And I'm sorry, I have SMA in here. It should have been Duchenne. And so we have these microscopic hairs that push particles up, and then we have to cough to expel them. So normal cough involves several different steps. Of course, you have to have a stimulus, a reason to cough. And then the next step is you take a big inhalation, then your vocal cords close, so you trap air in the chest, but your expiration muscles have to squeeze to develop a lot of pressure in the chest. And then finally you release those vocal cords and allow that pressurized air to come out. So if you have a problem in any one of those steps, you may have an impaired cough function. So what do I look for when I'm talking to patients, kids, young adults, families with Duchenne? The most important thing, honestly, is really to talk. is what's the medical history like as it relates to breathing function? Have there been hospitalizations or ER visits for breathing problems? Have you had pneumonia? How about a cough that won't go away because you just can't get stuff out? Or difficulty coughing, maybe you feel like you can't get stuff out. And then we also look at sleep, kind of a silent time in our lives. I hope at least it's silent and you're not snoring too bad. So we look for problems with sleep that may be pretty insidious. So snoring, sweating, morning headaches, which is a sign of potentially of disordered breathing, restlessness, and then of course daytime fatigue. In younger kids, we can also see ADHD-like symptoms. So they're just disorganized, they can't focus in class. There's a number of reasons for kids with Duchenne to have those symptoms, but one of them that we have to consider is impaired sleep. Then of course we look at the physical exam. So how does the chest move? And I like to lay kids down to see how their chest moves in the position that they sleep in, and then sit them up and see how the chest moves when they're upright. We look at respiratory rate. Simple pulmonologist exams just to watch a person breathe. How fast are they breathing? How much work are they doing? Are they really pulling with their accessory muscles in the neck up here or in between the ribs? Are they pulling hard to work? What's their speech like? So for my young adults and older patients with Duchenne, I just have them count to 10 or tell me the alphabet, and I count how many breaths they take to finish the alphabet or how many syllables they can say before they take the next breath. That kind of measures shortness of breath as well. We get oxygen saturations on every patient at every visit, and then we also do pulmonary function tests. And these are the four really that I care most about. The most important one is vital capacity, or forced vital capacity in most cases, and that simply means how much air can I exhale after taking a full breath. Then we look at peak cough flow. Some people call it cough peak flow, same thing. And literally this is a measure of how fast does the air come out when I cough. How much airflow can I generate when I do a full cough maneuver? And then we look at inspiratory and expiratory pressures. So how much pressure can I generate when I exhale as hard as I can, and how much pressure can I generate when I inhale as hard as I can? And those really isolate the muscles of exhalation and inhalation. And so we can get some clues there. On the right, you see pictures of a variety of people doing pulmonary function tests. I will say I couldn't find good pictures of patients doing PFTs with a mask, but we often have to do that, especially in our older patients who have oral weakness and can't get their mouth easily around a mouthpiece like this. The person at the bottom who's holding her own spirometer is not a muscle patient, but I do sometimes have my patients do pulmonary function tests lying down, because if there's a change in the vital capacity where it goes down significantly, laying down compared to sitting up, then I worry more about diaphragm function. So that's another positional test we can do. There are more tests that we can do. These are kind of reserved for an as-needed basis or a scheduled basis. So chest x-rays, sleep studies, spine x-rays can be really important to look at how scoliosis might be affecting lung function. We can do blood gases mainly to look at CO2 levels, and then swallow studies as the young men get older to look for upper airway musculature weakness. So I'm going to go through kind of 2 or 3 stages of Duchenne and talk about what we do in those stages, and then move forward into more treatment. So in the ambulatory stage, when our boys are still walking, we tend to start doing pulmonary function tests around 5 or 6. Sometimes with a very precocious 4-year-old, I'll try it, but I don't know that it means a whole heck of a lot, because we don't expect respiratory function impairment to be present at this age. So this is mostly practice and to get kind of baseline values for each individual patient. We look at oxygen levels, so easy pulse ox when you check in with your vital signs. And then we talk a lot about sleep symptoms, especially for kids who are obese, but for any kids. And then I talk a lot about immunizations, getting your flu shot every year, getting your routine childhood vaccines every year, and getting a pneumovax at this point once in a lifetime. In the early non-ambulatory stage, we start to get more concerned about respiratory function because we know, based on history, that respiratory needs are associated with the loss of the ability to walk. As we don't walk, we tend to take fewer deep breaths because we're not exerting our muscles. We don't need all that much oxygen to fuel our activities. And the chest tends to get stiffer and less compliant because we're not stretching it. And so we start to develop restriction or the inability to take in a big breath. And so we measure my 4 pulmonary function tests, the forced vital capacity, MIP, and peak cough flow, and oxygen levels every 6 months at every muscle clinic visit. I said it again, we check oxygen every visit. And then if the oxygen is low, less than 95% at sea level, then we check a blood gas to look at the CO2. In the early non-ambulatory stage, we also start thinking about lung volume recruitment, which I call physical therapy for the chest. And we usually do this around a vital capacity of 60%. And this is really kind of deep breath maneuvers with assistance. So you take a big deep breath, you don't exhale, take another deep breath, don't exhale, take another breath, don't exhale, and you reach your maximal inspiratory capacity, or how much air you can put in your lungs with successive breaths before you have to exhale. There's no real measurement here. This is just take successive deep breaths and stretch out the muscles and the joints in your chest. We start thinking about sleep studies in the early non-ambulatory stage, and I'll talk more about why when we think about sleep studies. And this is this phase in which some patients might need Bipap. And then this is also a phase where scoliosis starts to develop more because we're seated and we lose some truncal strength, and so we start to tip over or twist or get kyphotic. And so we start talking about spine fusion and how to prepare for surgery. In the late non-ambulatory stage, the cough continues to weaken, the FVC continues to decline, inspiratory and expiratory muscles and strength weakens. The risk for aspiration now rises because of tongue structure and because of oral motor weakness and chewing difficulty. And then we also have to remember that other things are happening at the same time. So in this phase, heart function tends to be declining as well in some patients, and that can impact respiratory function. And then we also have abdominal competition or constipation and GI motility or movement of food through the gastrointestinal tract that can push up on the diaphragm and make a weakened muscle work harder to maintain function. So this is kind of a table, or this is a table from the Lancet from the latest comprehensive Duchenne care guidelines. And this is the respiratory part of it. So this essentially summarizes what I just said in the ambulatory, early non-ambulatory, and late non-ambulatory stages. And so this is one of those takeaway slides. If you wanted one, this might be a good one. Here's how I think about the respiratory consequences of Duchenne. And we have to remember that for Duchenne, these happen slowly over time. It's not an immediate thing. So all these changes can be insidious. We don't necessarily feel them. And so it takes seeing your respiratory team frequently over time to figure out if things are happening. So we start with muscle weakness that can deform the chest wall and the spine so that the diaphragm and other respiratory muscles don't work as well. That in turn causes cough to get weak because you need all your respiratory muscles to cough hard. That leads to a buildup of mucus and a risk of pneumonia, which then causes more strain on an already weakened muscle system so that you breathe inefficiently and you get more fatigued, and that causes more muscle weakness, and you get into this vicious cycle going around and around. Of note, fixing a chest wall or spine deformity in any neuromuscular disease, and especially in Duchenne, does not change your lung function tests. It merely stops further impact of scoliosis from those impacts. It doesn't change muscle function. So let's go back to my simple cartoons of normal breathing. We have this balance between the tendency to collapse and expand. And when we lose our respiratory muscles, we tip over into a place where we tend to collapse, and so our chest shrinks, we get a smaller vital capacity. So here's Duchenne breathing at rest, and this is kind of in the non-ambulatory, more late non-ambulatory phase. So you have already a smaller chest. If you remember the previous cartoon, the chest here looks smaller and the one on the right looks more like Darth Vader. And then when you inhale, the diaphragm still contracts, but it's weakened, it's fibrotic, it has all the changes of muscular dystrophy. And so you don't get much of a change in lung volume. So it makes it harder to take a deep breath. So when do we start cough assist? So we start cough assist either based on numbers or based on frequency of chest infections, regardless of pulmonary function tests. And if I'm starting cough assist in an ambulatory patient, then I'm thinking, what else is going on? Is there asthma? Is there aspiration? Is there something else for this kid that isn't just muscular dystrophy? So usually we're starting this in the non-ambulatory phase. The published guidelines are to start cough assist when the vital capacity is less than 50% of predicted, or the peak cough flow is below a 270 threshold, or the expiratory pressure, how hard you can push out against a closed system, is less than 60 centimeters of water pressure. So what makes a cough weak? I think we kind of talked about this a little bit, but if you can't do any one of these things, you can't inhale deeply, close your vocal cords, squeeze with your expiratory muscles, or force exhalation, then you might have an impaired cough. And then we also have to remember there are other things that can make a cough weak too. So nutritional status, if you're malnourished or if you're overnourished, that can make it hard to move your chest. If you are not sleeping well and you're always tired, it makes it hard to cough. If you aspirate and you're kind of accumulating airway and lung injury, that makes it harder to cough. Reflux potentially leads to aspiration, or makes people not want to cough because it hurts their chest, it hurts their reflux. And then constipation, if you can't take a deep breath because you have a stool burden that your diaphragm has to push against, is a problem. I think it's important to remember that the problem is the cough, not the mucus that you're trying to get out. Most of the time, the mucus properties in someone with Duchenne are the same as anybody else. They don't have particularly thick mucus. They don't have particularly too much mucus on a daily basis. They just can't get it out. And so a weak cough means that you can mobilize the secretions, but you can't actually clear them. You can't ever get them out. And so our priority has to be cough augmentation with a cough assist device, which I'll talk about next. There are other things that you can do, but they don't address the main problem. So you can assist those microscopic hairs in your airway by doing chest physiotherapy, patting on the chest to break up mucus. You can use all sorts of devices like an IPV or a vest. Certainly in worst case scenario, we use fiber optic bronchoscopy, camera, and a tube to suction out mucus directly from the lungs. But these are all secondary to the cough. And the same thing in terms of medical mucociliary clearance. So you can think of all sorts of medicines that we mostly use in asthma and cystic fibrosis to help break up mucus. But unless you're going to cough it out, mobilizing and breaking up this mucus doesn't make much of a difference. So we have to focus on cough. So the official name for cough assist is mechanical inexsufflator, which if you know what an exsufflator is, then you know what it does. So essentially a cough assist blows air pressure and thereby volume of air into the chest, and then it flips a switch and suctions out, so it simulates a cough. It doesn't have to stimulate a cough, it has to simulate a cough. So a cough is a big breath in and then forceful exhalation, and that's exactly what a cough assist does. It is well tolerated. I really have not seen any gastroesophageal reflux, heartburn, aspiration from it. People worry, especially people who don't take care of muscular dystrophy, they worry about popping along or causing a pneumothorax. And we really have not seen that at all. We tend not to use cough assist in premature babies and things like that because they have different lung disease that is more prone to. Many of my patients and many of the patients across the country say, I just don't like doing it because it's uncomfortable, either because the mask on my face is uncomfortable, the pressures are uncomfortable, it causes my chest or my belly to be uncomfortable, or I do it and it just doesn't do anything for me. I don't get anything out. That's okay. It doesn't have to get anything out every single time. What it has to do is stretch your chest, and sometimes that chest discomfort that people feel, especially when they start using it, is muscles being stretched that haven't been stretched in a while. So sometimes that chest discomfort is okay. It's a sign of physical therapy for the chest. Cough assist is most effective when it's used regularly compared to only when someone is sick. And that's probably because when you're sick, you don't want to do something new. You don't want to try something new. You don't want to be experimenting with a new machine. It also, when you're sick, your chest is probably even weaker, and so it takes even more stretch to get back to where you were when you were well. So this definitely takes some practice, but over time there are relatively few complaints. We certainly tinker with settings and for comfort and effect. But once they're used to it, most kids and young adults actually start to ask for it when they're sick, which is when I know that I've won. Okay, so next question, when should we start breathing support? So again, there are pulmonary function kind of parameters for when to consider breathing support. And they're listed here: vital capacity less than 50%, and inspiratory pressure, so can't inhale hard enough to generate 60 of pressure. If your CO2 is over 45 or your oxygen is persistently less than 95, those are signs. But then we also talk a lot about signs or symptoms of sleep apnea and hyperventilation, regardless of what pulmonary function numbers are. So I have guys who have 85, 90% vital capacity who are on Bipap because they're really not sleeping well, and it's because of breathing. So in those cases, we get a sleep study, and then it'll tell us whether or not there's a need for Bipap. So about sleep studies, these can be problematic. Most sleep labs, if you have access to one even, are not set up for Duchenne or hypoventilation, not to mention like the hospital bed and all that other stuff that isn't there like you're used to at home. Most labs are set up for obstructive sleep apnea, and so especially if they titrate your Bipap settings, I've seen patients come out with all sorts of settings that don't really make sense for Duchenne, but might make sense for someone without muscular dystrophy who has obstructive sleep apnea. So there are a number of different ways to determine Bipap settings for someone. One is in the sleep lab, but as I just mentioned, there are a lot of limitations to that. The other couple of ways is good clinical reasoning and experience. This isn't scientific, but if you have an experienced pulmonologist and respiratory therapist, you can get pretty darn far. And then we can also use data downloads from the Bipap device itself. And that's really nice because that can show us data over a night, a week, a month, a year, and can really help us trend as we watch the vital capacity. And that's all done mostly now by Bluetooth, sometimes by modem. And so it can be a pretty quick turnaround. There are limitations to the information that we get from it, but we can see a respiratory rate, we can see how big the breath is, we can see respiratory effort, essentially how many breaths what percentage of breaths are triggered by the patient versus the machine. And we can also see duration of use. So while I don't use this to spy on my patients, I can certainly see how much you're using it or not using it. So these are kind of the parameters. I'm going to move quickly through these, but these are the parameters in general that I think about for bi-level support. There's pressure settings, there's time settings, there's a rate, there are different modes which we tinker with, and these are mostly for comfort, but also kind of have different theories as to why they might work in someone with muscle weakness. And I would leave that discussion to each patient and their pulmonologist and respiratory therapist. And then really the philosophy of bilevel support is to overcome breathing problems during sleep, to provide rest, and to treat hypoventilation. We can also support heart function with BiPAP. We can't fix heart dysfunction, but we can support it. And then we have to remember that this is a long-term outlook. So patient comfort is really the most important thing. And it may take time to reach optimal settings. So if you go to the sleep lab and they titrate your BiPAP and they say, you need 18/8. Well, that may not be the easiest place for a human being to start when they haven't ever worn BiPAP before. So often I do training wheels where I will put someone on low-level BiPAP and get them used to a little bit of air pressure, or even just practice during the day. The goal is to eventually get someone to wear BiPAP so that they can use it. The worst thing I can do is say, these are the BiPAP settings you need, and it's this or bust. It will always be bust if I do that, and we're not going to get anywhere unless we slow down. Okay, so here's how BiPAP works. So again, this is at the end of exhalation at rest. This is a small Duchenne chest, right? There's already muscle weakness, so inability to take a big deep breath, and we tend to collapse down. When we apply, oh, sorry, this is how not to do it. This is Cpap. So let's go back for a second. So Cpap just provides pressure, one single pressure all the time, doesn't increase the pressure when you inhale. So Cpap essentially applies pressure without the diaphragm contracting. It just opens up the upper airway a little bit and maybe inflates the chest a hair, as you saw this cartoon just barely expands. It doesn't really help you breathe when you have muscle weakness. So we don't do that. And then once you go back to exhalation, you kind of just get these tiny little breaths, not really helping you. So let's do BiPAP. Okay, so now I changed the letter from C to E. This is EPAP, or your expiratory pressure. This is the same thing as CPAP. You get a little bit of a distending pressure, but then you get your inspiratory pressure as the diaphragm contracts, and you can see you really inflate the chest nicely. Then you exhale back to your expiratory pressure, and then when you take your BiPAP off, say in the morning, you go back down to your resting volume. So there are a number of different ways to use non-invasive ventilation. You can use a full face mask that sits over the nose and the mouth. You can use an oronasal mask, which is similar. You can use just a nasal mask, which is my preferred method, or nasal pillows, another one of my preferred methods. And for daytime use, you can use a mouthpiece or sip and puff ventilation. And we'll talk about that a little bit, but that's a fantastic way to provide breathing support during the day. Oh, here it is. So when do we start thinking about daytime support for Duchenne? Well, oftentimes post-op or with any kind of sedation. So if you're on pain medicines that affect breathing, either by affecting muscle strength or by affecting the brain's drive to breathe, then daytime support is a really good idea. If you have symptoms of daytime hypoventilation, so fatiguing toward the afternoon, getting foggy thinking or difficulty concentrating, needing naps in the middle of the day is potentially a sign of daytime hypoventilation. And that's the choice to use ventilation during the day is really driven by comfort and need, but mostly by comfort. As I said, you can use a sip and puff or mouthpiece mode, and tracheostomy is also an option. But it is an option, it's not mandatory. And so your choices, your young adults' choices often are the right ones. My job is only to inform and to help people make an informed decision, not to decide for them or not to judge that decision. I have a young man right now in the hospital who electively decided on a tracheostomy because he couldn't stand having his nasal pillows device on his face all the time. And mouthpiece didn't work for him because he didn't have the oral control to keep the mouthpiece in. So he elected for a tracheostomy. He's a week and a half out. He's exceedingly happy to get all the junk off his face, and his voice is actually stronger. So it's a right decision for him. Others have said, I will never go there. And I say, cool, I'll go on this journey with you. So what about acute respiratory care in case of illness? So use BiPAP early. If you have a BiPAP device, it is okay to use it, even if you usually only use it during sleep. It's okay to use it during the day for support and for rest. Remember, oxygen alone, Cpap, even a high flow nasal cannula device for oxygen delivery is not appropriate in Duchenne. It's BiPAP. Cough assist is a must, right? It's the first response to low oxygen, is get the mucus out. Most ERs that are not familiar with muscular dystrophy will slap some oxygen on and say, see, the number went from 85 to 92. Much better, thank you. Well, that's not addressing the problem. The problem really isn't low oxygen, it's what's causing the low oxygen. And for young men who can't cough, they can't cough, so we have to cough for them. You need to have a plan, and I will show you what some of my plans look like. Please bring your respiratory equipment to the ER and to all planned surgeries. Bring your BiPAP machine, bring your tubing, bring your mask, bring your cough assist. Even if they don't use those devices, they'll at least be able to see what your settings are. And eventually they'll be able to get back to using your devices. We often do blood gases and chest x-rays, and we use antibiotics relatively liberally when there are respiratory concerns. And then I always, even though I am a lung doctor, I always mention to people when they call me, don't forget the heart. We have to remember that the heart is affected in muscular dystrophy. And if we're sick, sometimes it's a little bit hard to tell whether it's respiratory primarily or cardiac. But we also know that respiratory illness affects heart function, so we need to watch out for that. So I know this is small print, but this is what we've developed at Children's Colorado for each one of our patients. So the left side is our respiratory action plan. If anyone has asthma or a child with asthma, you'll notice that this looks relatively similar. There's a green zone, yellow zone, and red zone. Green is when you're doing well. It's what we want you to do on an everyday basis. Yellow is kind of caution, not feeling great, and on the left column there are symptoms of what you might look for to tell you that you're in the yellow zone. And it says, call your team, call your PCP, use your non-invasive ventilation, even during the day, and increase suctioning and cough assist if you have those things. And then look out for dehydration to make sure that you are hydrated. And then the red zone is the medical emergency. So use your BiPAP now, use your cough assist now, and get help. On the right side, which is usually the second page of our respiratory action plan, we have, and then the blacked out stuff is kind of contact information and who this patient is. But this page is about what your settings actually are. So this is helpful to bring to surgery or to an ER, and you say, this is what I have, this is what I use, these are my settings. And it also has our contact information, so we want to know when our patients are in an ER or in a preoperative situation. Okay, COVID. Good news is that very few kids are getting sick, really quite minimally. And those who do get sick are not getting very sick. Most have cold symptoms, sometimes flu-like symptoms. They're staying home. They feel crummy, but they're staying home and they get through it. Some are hospitalized. I just looked at our data here today. Right now we have 5 or 6 patients hospitalized at Children's Colorado with COVID. Across the street at our university hospital, there are about 50 patients hospitalized. We rarely see kids end up in the ICU, as opposed to adults, and especially older adults who frequently end up in the ICU. And then specific to neuromuscular diseases, I think the surprisingly, it's even better than what I just said. And I don't know why, no one knows why, but we're happy for it. And that's that kids with Duchenne and even young adults with Duchenne are not ending up in the hospital. I haven't seen one have any symptoms of COVID. I've tested one young man, he was negative. And I take care, by the way, of young men with Duchenne throughout their lifetime. So I have patients in their mid-30s, and they're simply not getting sick. I don't know why that is. We have some theories as to why kids don't get sick from as much from COVID, and it's specific to lung development and some molecular biology that I barely understand. But I don't have a great explanation for why young adults with Duchenne are not getting so sick, but I am thankful for it. It's quite possible that many leave more sequestered or isolated lives anyway. But there are many, but I think the elderly also lead relatively isolated lives potentially and have been hit very hard by this virus. So there's something unique in this situation. We still recommend good hand hygiene, wearing masks if you can tolerate them. Social distancing is important. And then using telehealth for physical therapy and even doctor's visits. Telehealth has some nice advantages and disadvantages, and I think it's here to stay. So we may see a mix of telehealth and in-person visits in the long-term future, even once we have control of this pandemic. I do want to say that hospitals and doctors' offices are safe. They're potentially the safest place you can go because everyone is so hyper aware of hand hygiene and wearing a mask and sanitizing everything. I don't know what's going to happen with school. I think that's a regional decision based on local infection rates. I honestly don't know what's going to happen with it, but I would be a little bit concerned about sending a kid back to school if they have any medical issues. That's not to say that they shouldn't go back to school. That's a family decision. But I want to see maybe how kids without muscular dystrophy are affected first. Okay, so in summary, respiratory care is a team effort, and I in most of my talks I have a slide as to who's in the respiratory team. It's kind of everyone. All patients with muscular dystrophy need a breathing team. Early involvement is important and ideal. And talk to your team early and often about options and choices and how to design a plan that's specific to you. Oh, one back. Okay, so there you have it. I wish that was the view from my office, but it's not. I look at the dental school parking lot. I've put in a link at the bottom of this slide for a really nice series of pulmonary awareness kind of animated videos. They're about 5 minutes long. I think there's 5 of them that were made by PPMD. These are really nice, kid-friendly, and that they talk about what to expect at the pulmonary visit and how respiratory care kind of evolves over age. So that's what I've got. I'm happy to take any questions. So we have a question here. What is a breathing team? And I'll get to the next question in a second. So a breathing team really is one, the patient and the family, pulmonologist, a respiratory therapist, and then a whole lot of other people. I think of a nutritionist or dietitian as part of the breathing team because nutrition plays such a vital role in muscle function and in overall health that they really are important to your child's respiratory health. For the same reasons, I think an orthopedic surgeon is part of your breathing team. Now, I said that fixing scoliosis doesn't fix the muscle disorder and doesn't fix any restriction or loss in lung volume, but fixing that spine certainly can prevent further losses. The sleep lab is part of your breathing team. Your cardiologist is part of your breathing team. The number of times that our cardiologists call me or I call them because we're trying to figure out what's breathing related and what's heart related, quite frequent. So all those people are part of your breathing team. Think your home respiratory equipment company is part of your breathing team. The respiratory therapist that comes in your house is part of your breathing team. So it's a big team, but it's centered around you and your child and your pulmonologist and RT. Okay, let's see. What's the difference between CPAP and BiPAP? Great question. I kind of skimmed over that a little bit. CPAP stands for continuous positive airway pressure. That is one pressure all the time, and it tends to be relatively low. That is intended to push open the upper airway and just overcome obstruction. So fat guys like me have to wear CPAP because we tend to snore and we have collapse of the upper airway when we sleep. BiPAP, bi stands for bilevel positive airway pressure. So you get essentially a CPAP level, a lower pressure, and that keeps the upper airway open when you exhale. And then when you inhale, it gives you another pressure to give you an actual breath to breathe in. Okay. Let's see, next question. At what age do I recommend cough assist? So it's not so much age related as symptom and pulmonary function related. I'm seeing most patients start on cough assist somewhere between probably 13 and 15, but sometimes later and sometimes earlier. So when the thing that I look for at every visit, even before we get our PFTs, is have you had any respiratory illnesses? Can you cough hard enough to get mucus out? What doesn't work is listening to someone's cough and saying, oh, that's a loud cough. Well, I can clear my throat pretty loudly, but it has nothing to do with getting anything out of my chest. So listening to the volume of someone's cough probably doesn't help a whole lot. And then we look at pulmonary function. So as I said, a vital capacity less than 50% predicted, or an expiratory pressure less than 60 centimeters of water is an indication for cough, or sorry, a peak cough flow of less than 270 liters per minute. And I'm sorry, I'm not getting any feedback on the answers, so I hope these answers are adequate for what you're looking for. Okay. Next question, when should I bring my son for a sleep study? The official guidelines from that were published in 2018 in the Lancet Neurology recommend a sleep study annually once boys stop walking. That has all sorts of caveats to it. The most important one is access, and the second most important one is what can your sleep lab actually do. In the adult world, most sleep labs do not measure CO2 levels, and so they will often miss hypoventilation, which is one of the major issues in Duchenne that we're looking for in a sleep study. Sleep labs are also not trained to look for subtle signs of hypoventilation like rapid breathing, shallow breathing during sleep. They're really just looking for, does your oxygen go down and did you stop breathing? And that's probably too crude an instrument for what we're looking for. Some people will ask, can we do a home-based sleep study? That's never been validated in children, and that's specifically for sleep apnea. Home-based sleep studies are not sophisticated enough to find what we're looking for in adults or in children. And so we do not recommend home-based sleep studies. If there's an issue with access and the only way to assess someone's breathing during sleep is with a home-based sleep study, I suppose it's reasonable, but it doesn't fulfill the gold standard. The good news is that currently the Centers for Medicaid and Medicare guidelines for approving non-invasive ventilation, BiPAP, include a caveat for neuromuscular disease. So if you have neuromuscular disease and your vital capacity is less than 50%, or your inspiratory pressure is less than 60, or your CO2 is greater than 45 on a blood gas, or your oxygen is less than 95% overnight, then you qualify for a BiPAP machine without a sleep study. So you don't have to have a sleep study if you meet those criteria. Now, some patients have their lung function better than that, but still have sleep symptoms, and so we can't use those criteria to get them a Bipap machine. Okay. How many times a year should their breathing be checked? In the ambulatory phase, we recommend once a year pulmonary function tests. Most major centers will do it more frequently for a number of reasons that are practical. One, most patients are coming to the clinic perhaps more than once a year, and so we take the opportunity to do pulmonary function tests because it's a learned skill. So young boys have to practice doing it in order for us to get good, reliable results. So my practice is every time a patient comes to the neuromuscular clinic, we do pulmonary function tests. That may not mean that I meet with the family every time, but at least we practice the pulmonary function tests. Do I recommend vest or cough assist? Absolutely cough assist. Cough assist addresses the single most important impairment in neuromuscular disease, which is inability to cough. The vest will shake up mucus. It might move mucus up from the far reaches of the lungs, the alveoli or the small airways, up to the major airways. But without a cough, that's never going to come out. So it just stays there and eventually sinks back. Some patients will use, especially in more advanced disease, will use a vest to loosen mucus up, to move it more centrally, and then use a cough assist. That is reasonable. That's a more individualized care plan that you should discuss with your RT and pulmonologist. But the mainstay of therapy has to be cough assist. If you had to choose one device for airway clearance, it's got to be cough assist. And that's in someone with an impaired cough function. There are rare cases, or not so rare cases, unfortunately, where someone has already gotten a vest through their PCP or somebody else, and then I want to order a cough assist machine. And in some locations, that can be quite difficult because local Medicaid, state Medicaid, will only approve one airway clearance device every several years, and so we're kind of stuck without what we need. There are ways that we can work around that, but it tends to be pretty difficult. So if you had to get one airway clearance device, it has to be cough assist. Let's see. If my son looks like he has pneumonia, what do you recommend doing? So this depends a little bit on what stage and what lung function we're talking about. But in general, even if an ambulatory child with Duchenne looks like they have pneumonia, I would get a chest x-ray to make sure that we see it, because the other thing we have to think about is heart function. I would check oxygen levels and watch work of breathing. How fast is the child breathing? How hard are they working to breathe? Are they pulling with their neck muscles or the muscles in between their ribs, the intercostal muscles? I would not just supplement with oxygen. So if you go to your primary care doctor's office and they say, yep, I hear pneumonia on the right side, or they get a chest x-ray and they find a pneumonia and they say, man, your oxygen's 89%. Let's put you on a couple liters of oxygen and send you home. That's not good enough. I really worry about that. And so that might be a case where we more urgently start cough assist, or at least have someone in the hospital for a night to see if they need it. They may not need it if they're young enough, but we need to know about that, and we need to be really cautious about that. If you're a little bit older, if you're non-ambulatory, and you look like you have a pneumonia, again, chest x-ray, a little bit more detailed evaluation in the emergency or urgent care setting, and a call to your neuromuscular team. It's really important to give a call to your neuromuscular team, even if it's just an FYI, because what we often do is we will call ahead to our emergency department and say, this kid has muscular dystrophy, they are coming, and these are the things I want you to think about. So we can prime people's brains for how we want them to think about muscular dystrophy. And then we also want you to bring all of your equipment to the ER, and we want you to bring your respiratory action plan, if you have one, to the ER. Let's see. If my son is sick and is getting care from a local hospital instead of a Duchenne center, what do you recommend? This is a common problem. I live in a state where we cover 7 states around us with a catchment area of several million square miles. So this happens all the time. We want contact. We want the local providers to feel comfortable enough to call us. And sometimes that takes some advocacy on the parents' part to please call the pulmonary team or please call my care center and let them help you. And if they don't have the resources, if they don't have a cough assist machine, for instance, or if they're not comfortable with BiPAP in young tweens or teens, then it may be time to move your child to a larger center for their acute care. And so, but that's really a discussion we should have with the medical providers there. I know for our center and most Duchenne centers, we want the phone call. We want to over communicate rather than under communicate. We really want to know what's going on with your child and how to help the local providers help you. Okay, what about Albuterol or Zopanx inhalers? So I only use these in select circumstances when a child also has asthma or also has other issues bringing up mucus. Again, the most important part of airway clearance is cough assist. But if we're having bronchospasm or asthma type symptoms, absolutely, we can use it. Albuterol and Zopanx also help those microscopic cilia beat faster and move mucus out of the chest faster. So if we're still having trouble after appropriate hydration, after good cough assist settings, after using BiPAP, then I will sometimes add an inhaled medication to help things along. But again, it can't be the only response. It can be part of the package. Do I recommend a nebulizer? So that's the same answer as I just gave. Not on a routine basis, but if it seems to work for your child, that's part of their respiratory care plan, then we absolutely can do that. When we go for a sleep study, and I recommend CPAP. When we go for a sleep study, they recommended CPAP. Mom says to ask for BiPAP. Mom is right. I don't know what else you argue about with your mother, but don't argue about this. BiPAP is absolutely correct for the reasons we talked about before. BiPAP is really the only mode that helps someone inhale. It's not just pushing open their neck to overcome obstruction. It's really to get a big deep breath in, which is what the weakened respiratory muscles can't do. So BiPAP is absolutely the right answer. Some places will use variations on BiPAP, like AVAPs. That is also acceptable as long as there are 2 pressures that help you inhale and then keep your chest open when you exhale. That's what you want. A BiPAP machine for Duchenne also must have a backup rate. It cannot be in spontaneous or S mode only because hypoventilation has to be treated with regularly timed breaths. And so some providers will prescribe a BiPAP S device, and that is also not good enough. It has to be a BiPAP with a backup rate. You'll see that backup rate abbreviated BUR. Sometimes that's what that means. Okay, I think I've gone through all the questions. What kind of time do we have?
I think that was a perfect hour. Thank you so much for that presentation, Oren. That was fantastic. And I think great questions were asked and answered. But if that's it for everyone and there's no more questions, we can shut down this webinar. But I'd just like to say again, thank you so much for joining us today, Oren. It was fantastic. And we're so thankful to have clinicians like you committed to our community. But if anyone has any questions, we'll be sharing this with the community as well, which will include his contact information, and we'll be also posting to our website, which you can find on our virtual events calendar and with a list of all the recordings so far that we've had. So thank you all for joining us today, and thank you again.
All right, thanks everyone. It was a pleasure talking to you, even though I couldn't see or hear you. Take care.
Thank you.